Hi, everyone. My name is Mohan Ravi. I am presenting our research on examining pain management malpractice claims from incarcerated patients in the last 20 years. Managing chronic pain is already a pretty difficult task for providers given the ongoing opioid crisis, but it can be especially complicated in vulnerable populations, including the incarcerated patients. While there's limited epidemiology, studies show anywhere from 25 to 40% of incarcerated patients are suffering from chronic non-cancer pain, with population aging playing a role into this. But undertreatment of chronic pain is also systemically apparent. In one study of 102 imprisoned patients in Texas, 64% of patients were reported receiving inadequate pain management. There are a lot of barriers standing in the way of prisoners' adequate pain management, including regulations on prescribing analgesics, staff reluctance to prescribe them or administer them, limited prison formularies, poor pain management training, and patient-related factors as well. We'll get into that. But unlike non-incarcerated individuals, prisoners often have no choice in selecting an initial provider to manage chronic pain, nor the option of a second opinion. So with limited options, many incarcerated individuals seek recourse through the legal system. And this study seeks to investigate whether prisoners who pursue legal recourse for inadequate pain management can successfully litigate their claims and alter their treatment regimens. And we describe the reasons here for seeking legal action and the reasons for the case outcomes. The question ultimately bears significant ethical and policy implications, which we will consider following the analysis of some legal cases. So what were our methods? Well, we performed a search of the LexisNexis academic legal database. And what is this database? It compiles all the court decisions and associated opinions across the United States, the state and federal appellate and Supreme Court levels. It's been used for similar searches in the medical malpractice fields of dermatology and urology. And in order to find the relevant cases, we queried the database for cases at the federal and state levels using the term medical with intent of malpractice and prison pain management opioid, following the other papers in this area. The search revealed about 131 appellate cases. After the initial search, a full text review was performed, with the inclusion criteria being that it has to be a defendant that's a healthcare provider, a plaintiff that's a prisoner who's treated at the time in the prison setting. Number two, has to involve opioid pain management. And finally, it has to have a final decision. And after that, we also removed any duplicates. So about 82 total articles involved as a whole. So what did our results show? Ultimately, of the 82 cases, all 82 cases had plaintiffs that were male. Most cases were in the Ninth Circuit, which was more the Pacific Coast. That's California. It's about 53% was California, Washington, Oregon, and so forth. And the most common healthcare professionals named in this were physicians, 96.3%, with the rest being nurse practitioners. Regarding the rationale for lawsuits, the holdings of the cases, most cases were decided in the favor of the defendant, which is the healthcare provider, about 72 or 87.8%. Only 7 holdings, 8%, were actually in favor of the patient, the incarcerated patient or the plaintiff. The rationales for the lawsuits were also was talked about in this case, with the most common rationale for lawsuits being failure to completely treat their pain, which is about 46% of the cases, failure to offer pain management in the first place, which is 41%, and the delay of pain treatment, which is about 7%. In the cases that were won by the defendant, the most common rationale for the verdicts of patients where the physicians were ultimately won the case was that there was no deliberate indifference that occurred. And this is important to talk about a little bit. So in this exploratory study, we found that most cases ruled against the patient. Like we said, about 88% of the cases ruled against the patient. While most cases were brought in the Ninth Circuit, which is the Pacific Coast area, the cases occurred in all U.S. Census Bureau regions, demonstrating it's a national concern. Most cases named the physician in charge of care for their respective prisons as the main plaintiffs, though nurses and other healthcare providers were definitely involved or named in the case. The failure to offer adequate pain management medications was the most common rationale for lawsuits, with defendants often claiming that opioids were indicated and not given for pain management. Plaintiffs, the patients, most often claimed that refusal of opioids were there due to concerns of addiction and abuse. And opioids were often refused despite evidence indicating that addiction tends to be rare if the use is limited in the acute pain setting, even in those who have a history of substance use. Cases were most often decided on the deliberate indifference standard, which is another thing that we'll talk about further. Let's talk about how, in our analysis, prisoners are rarely successful in pursuing legal recourse for negligent or substandard pain. So for your typical provider, which I'll call the community provider, in civil courts, the burden of proof for medical malpractice requires that 1, the defendant had the burden of care, number 2, that substandard care was provided, number 3, that substandard medical care resulted in an injury. However, healthcare providers employed by prisons maintain a qualified immunity status that makes medical malpractice claims exceedingly difficult to win in the civil courts, which is why prisoners must often resort to constitutional claims alleging violation of Eighth Amendment rights against cruel and unusual punishment. Another reason why in the federal courts, this was actually more cases were done in the federal courts. To win these claims, though, they must successfully prove what we call a deliberate indifference in their care. This requires that the prisoners show that the prison official, in this case the provider, had 1, subjective knowledge of a risk of serious harm, 2, disregarded that risk, and 3, acted with conduct that's more than mere negligence. So treatment below standard of care is insufficient to demonstrate deliberate indifference, making legal recourse for substandard care exceedingly difficult for prisoners. In some cases, judges ruled that physician defendants were possibly negligent in providing adequate pain management options, but such negligence did not rise to the level of disregard or harm required to prove the physician was deliberately indifferent to the prisoner's pain. So even when the patient has medical clearance for opioid analgesics, a prisoner can easily have their medication discontinued for systems level changes outside of their control, such as prison transfers. Johnson v. Chow provides a poignant example of this. The defendant received medical clearance from morphine by his neurosurgeon for severe multi-level cervical spondylitis. This continued in one of the prisons he was in, but when he was transferred to a separate facility, the provider refused his morphine and instead prescribed methocarbamol, which was not helpful for the patient. Johnson v. Chow echoes the same concept in Areola versus Pomazol, Long versus Kaplan, and Uriarty versus Lewis, in arguing that a prisoner can receive inadequate pain management through discontinuation of previously prescribed analgesics for reasons other than standard of care. These differences in practice between prisoners and prisons demonstrate a lack of standardization of care, an area for possible improvement. And despite likely or proved negligence, the deliberate indifference standard was an insurmountable barrier for most prisoners. In all of these cases, the prisoners lost the case. This included both continuation of chronic pain treatment initiated prior to incarceration and in other prisons prior to transfer. The lack of adequate recourse also raises some ethical concerns, which we'll talk about briefly. So when we look at a principalism-based analysis, we see that some ethical violations might happen in multiple domains. Autonomy requires that an individual be able to participate genuinely in decision-making and provide informed consent. While prisoners have legitimate constraints on autonomy, they ought to have medical options available to them that meet some minimal standard of care with a reasonable outlet to review if the response is not adequate. The principles of beneficence and non-malfeasance may also be relevant here. While the data supports short-term opioid use, they do show that only short-term opioid use might have a small to moderate impact on pain acutely. Opioids may not be justified in all cases of pain management. However, for patients on established regimens or for whom opioids are otherwise indicated, the principle of non-malfeasance would require that regimens not be disrupted. Individual assessment and review are required, and systematic denial of opioids would violate both principles here. There's also a concept of distributive justice. This is where the prisons would need to have health resources viewed under the veil of ignorance. Correctional facilities are obligated to provide equivalence of care that meets the broader standard of care. Our analysis here notes that many cases in which the plaintiff sued for restoration of treatment regimens previously determined to be appropriate in the community setting by a pain specialist or other providers. And so one example is Ballard versus North Carolina Department of Public Safety. The patient in this case, had been on an oxycodone pain regimen from 2004 up to his incarceration starting in 2013, during which, at the time of incarceration, it was revoked. Presuming his pain regimen was prescribed for a legitimate medical indication, its removal without an adequate pain replacement, even in a non-opioid medication, represents a violation of beneficence. Denial of efficacious pain regimen accepted as a valid treatment in the community for years upon transition to an incarcerated setting violates the equivalence of care edict of justice. The patient had consented to a reasonable treatment decision outside of incarceration and then was stripped of his ability to freely choose said treatment plan, which is a violation, we believe, of his autonomy. And lastly, this decision may have caused both direct harms from the lack of analgesia and indirect harms from seeking out alternative analgesics, which may have been illicit substances, which is a violation of non-malfeasance. Such cases here highlight the ethical concerns of pain management in the correctional setting. So there's also a lot of factors in the prison setting that are so different from the civilian setting. And one of the things that we want to talk about is on the patient level. Physicians may be reluctant to provide opioids even when indicated because of the risks of things like substance use. Incarcerated patients have a higher prevalence of substance abuse history, as well as higher rates of psychiatric illnesses, which may themselves contribute to a higher risk. In addition, physicians do note in multiple studies higher rates of malingering, drug-seeking behaviors within the prison populations, making them wary of the opioid prescriptions. And finally, they may just be at a reluctance to prescribe given there's a high risk of diversion, particularly frail patients who may be subject to coercion by other prisoners. Physician level factors may also impact this pain management. Only some physicians who are providing care to prisoners are specifically trained in pain management. And so while this training covers addiction medicine and medical management of common pain syndromes, even that training doesn't acknowledge systemic barriers for pain management in the prison settings. And different pain management philosophies may also influence the treatment prisoners are able to get. Even among non-prison family medicine physicians, there's a wide range in willingness to provide long-acting opioids. Additionally, physicians in the prison settings suffer from dual loyalty to both the patient and the prison systems. And so the physicians may be influenced by security concerns and may need to treat a patient to align with the prison administration desires. Prison physicians are also ultimately subject to prison policies. And some of these policies are more systemic, prohibiting any use of opioids within the prison system. Allen versus City of Cayuga was a good example of this, where it interfered with proper pain management that both the physician agreed with to provide an opioid in this case. Additionally, physicians may not be able to prescribe an opioid if it's not in the prison formulary. And there's a lot of limitations here. While opioids are available in the federal prison formulary, this may not be true of state and multiple state prison formularies. There's also a lot of differences in therapeutic options between states and individual prisons, including the non-narcotic prison policies, which means that care available for incarcerated patients likely differs widely between individual prisons. So what are we asking for? In our analysis, we found that pain management approaches in the prison settings raise ethical and medical concerns about meeting a standard of care for this vulnerable population with limited legal recourse. However, we do acknowledge there's a complexity here of implementing opioid-based pain management settings in the prison settings. And so to address this, we propose a systematic evaluation of pain management practices in the correctional health setting and creation of chronic pain management guidelines specifically developed for the correctional health settings. While the CDC has issued guidelines for chronic opioid use in the general population, these guidelines fail to consider this unique population and should be updated. Strategies such as pain management panels could be employed as one way to provide evidence-based care for the patients, and if utilized, they should be consistently and equitably available between facilities. Unified policies and guidelines at the federal and state penitentiary level regarding the treatment of incarcerated patients' pain are a key component to upholding this justice principle. Guidelines will not fully solve this complex issue. However, patients will have a more standardized care across institutions with the goal of minimizing victimization when it comes to denying opioid pain medication. And additionally, during legal proceedings, the patients can refer to the guidelines to demonstrate whether they were followed. For providers, guidelines decrease uncertainty during medical decision-making. Violation or adherence to the guidelines might provide a legal system with better evidence than deliberate indifference when considering malpractice claims. And ultimately, the goal of guidelines would be to provide optimal care for patients. So we also want to, recognize that our goal here is not to advocate for a wholesale increased use of opioids in the prison setting. Indeed, prescription opioids continue to contribute to the opioid epidemic in the United States, responsible for almost 15,000 deaths in 2018 alone. Consequently, there is an ever-increasing and understandable level of scrutiny on opioid prescribing patterns of all providers, especially in pain. Importantly, we must balance the scrutiny while considering the analgesic needs of the patients in the prison setting. Our key objective here is to balance the prisoner's rights, in this case, their right to standard of care and adequate pain management, with the risks associated with the opioid use, especially given the ongoing opioid crisis. That we don't seek to argue that prisoners are being subject to cruel, unusual punishment in violation of their Eighth Amendment rights. We nonetheless believe that prisoners should be not left to struggle with inadequate pain management and they're owed a standard of care in general with regards to that. In that light, it is worth it to explicitly recognize that opioid use in the prison setting may be appropriate for some, while carefully taking risks and benefits into consideration. One of the big limitations in our study is that we primarily looked at mostly appellate level cases, with very few trial court level cases included in this database. This limits our total sample size, and as many cases concerning pain management in the prison populations likely didn't even reach the appellate level. Additionally, while details concerning the patient cases are included as part of the case facts included in each decision, full details from the medical charts are unavailable for analysis. This limits the degree to which each defendant's medical needs can be assessed by us, and thus limits the degree of certainty with which applicable standard of care for that patient can really be inferred. But what we can say here in conclusion is our analysis shows that there is inadequate pain management in the correctional setting. And we found that prisoners were often unsuccessful with litigation despite several cases suggesting current management practices do not meet minimum standards of care or are ethically concerning. Violations are not solely due to a singular practitioner or entity, but often are attributable to systemic barriers. Legal recourse is often a nearly insurmountable barrier to obtaining adequate pain management due to the high legal burdens of demonstrating inadequate care. Therefore, a different approach is required. We propose a comprehensive review of pain management and the development of an evidence-based guideline for correctional facilities in line with pain management approaches for the general population. Thanks so much. That is all I have for today. I very much appreciate the opportunity to present this to you guys. Thank you. Bye.